There we go. All right, ladies and gentlemen, I'd like to introduce you to Dr. Matthew DrEschebach. Dr. DrEschebach is our assistant medical director. He works with us mostly to help us out just for this purpose. MD roundtables are his specialty. Dr. DrEschebach is, of course, I cannot, excuse me just a moment. I'm having technical difficulties. There we go. He is the medical director for EMS and trauma up in Redmond, Oregon, and he is also the medical director, I believe, for some EMS response organizations up there, and he speaks quite a bit in conferences and other circuits involving emergency care for the pre-hospital environment and otherwise. So I'm going to keep you all muted, but Dr. DrEschebach may be checking in with you occasionally and asking questions, or if you have a question, you can unmute your mic and ask questions, and then once you're done, please remute your microphone so the noise around you won't bother anybody else. I do see Carmela has come in now too, but basically we'll get to the end of this thing and we'll do another check of you and make sure everybody's there, give a chance for you to answer questions, and then I will grant credit from that point. Before we start, Meshullam, I have like 3 Meshullams in the classes. What's your last name and which class are you in?
Lesniansky, in the paramedics, so 400E, I think.
Got you. There you go. Got you. Thank you, Meshullam. Yeah. All righty, Dr. DrEschebach, they're all yours.
All right. All right. Good evening, everybody. I looked over my notes, and it's 2 years since we went over stroke, so that's why I'm going to go over stroke with you tonight. And the reason why stroke is such an important topic is EMS is on the forefront now of deciding not only how to transport and when to transport, but where to transport. And as we go through some basic skills and understanding of stroke, we'll show you why it becomes necessary for EMS to be completely aware of what a stroke is and how it works. So we're going to start with just the basic, and that is a neuron. And the neuron is the basic nerve cell. These are the ones that talk to each other. It's the dendrite or the axon. And you can see that these little fibers down here, the telangiectasia, will hook up to the next nerve cell, and that is how a signal is propagated. Now that signal of propagation from neuron to neuron is what's important for nerve cells to be moving certain parts of the body, or speech, or coordination, etc. They happen when they touch each other. They wind up with these electrical impulses. So at the basic level, neurosynaptic nerve cells talk to each other through these tight junctions where electrical charges are passed over and neurotransmitters are passed over. And if there's an interruption, just like cutting a line of a cord for a lamp, if there's an interruption in that, the impulse does not get through. So stroke victims in and of themselves are what we're going to call a brain attack. And there are several types of brain attacks, and we'll go over a few of those terms in just a minute. But here's an example of a recent EMS stroke in our area. Someone came called in. The paramedics were called to the house. They assessed that a patient was having a stroke, and they were able to get them to the correct center. They were able to bypass one hospital, and it was about 15 minutes to one hospital without intervention and about 18 to 20 minutes to the hospital with intervention, and they went to the intervention hospital. And the picture on the left is a stroke of the left middle cerebral artery. And this is going to cause a classic series of symptoms. And the symptoms are going to be arm weakness and loss of ability to look to the left or right, depending on where the stroke is. And on the right is the same person after they've had the stroke taken care of. So you can see on the left that there is quite a bit of circulation missing. And then the arrow on the left is pointing to where the blockage is. And then on the right, all of this is the brain that would not have gotten circulation. So whether or not you call it a stroke, CVA, which stands for cerebral vascular accident, brain attack, apoplexy is a very, very old term for people not being able to think and talk correctly. These are all essentially strokes. So, excuse me, I took this picture out of a 2005 lecture I did that was called Stroke, Hurry Up and Wait. In 2005, that's when the American Heart Association brought stroke into the ACLS algorithms, and EMS was told to rush everybody to the hospital. And quite frankly, we were getting an onset of people rushing to the hospital, but waiting around to do nothing at that time. We did not have anything in place that resembled a stroke center. We had heart centers and we had MI, heart one centers, but we did not have anything that represented a stroke center. The public was poorly informed. The American Heart Association really kind of jumped the gun because we didn't have the framework to get people into the right place. And it took some 15 years to get that going. The response time was too slow. Very often presentation was too late, and hospitals were ill-prepared, which left us with a downtrodden or fatalistic view. Today, in 2020, the public is informed, and we wind up seeing quite a few billboards that talk about stroke. Our response time is better. Presentation is never too late. I'll come back to this. It used to be that we could give TPA within 3 hours, and then it was pushed out to 6, and now strokes are treated up to 24 hours. Hospitals are much better prepared. We have a much better optimistic view, and we have clearly defined protocols in place most of the time. And I'll talk about some of the downs with that. Of course, it starts with the idea from the American Heart Association and the chain of survival. You've got a chain that goes from the community to pre-hospital, which is EMS, and then the receiving hospital. And the links in those chain are rapid detection, EMS response, EMS delivery to door, and we'll keep that as short as possible. Rapid and decision to drug usage for the ER physicians, and getting these people to stroke units as soon as possible. You combine that with the suspected stroke algorithm and advanced cardiac life support. What you're going to add is a few other things there. Oxygen is indicated for hypoxemic patients. You're going to do a pre-hospital stroke assessment. Check the glucose. That's very, very important, and that's in every EMS protocol, because you don't want to rush somebody for a $50,000 test if their $2 glucose test is, 35. So that's bad form. Try to establish the time as much as possible so we can get a timeline going on. And then you're going to triage to the appropriate stroke center, alert the hospital, and then the stroke team will be activated. And all of these are possible. So the community link is, you're going to see this quite a bit. You're going to see this on billboards. I've seen this in billboards in major cities, and kind of cueing people in to what a stroke looks like. And that's what this FAST is. Facial drooping, arm weakness, speech difficulty, and then T stands for time. It's time to call 911. There's even a Google or iPhone app for that. At St. Charles, where I practice, we actually added the word B in front of FAST because we've got people we want to keep in mind two different types of strokes, which I'll go over in a few minutes, and where somebody's balance or their eyes are affected. So B FAST is part of our recognition process. And we've done community development based on B FAST. So keep in mind what a brain attack or a stroke is, and these are all CNS emergencies, and they all trigger on types of ischemic stroke. Ischemic, as you remember, is inadequate blood flow, in this case to the area of the brain. When we talk about ischemia in an EKG, we're talking about flip T waves or something like that, and that's inadequate blood flow to heart muscle. But when we're talking about strokes, we're talking about inadequate blood flow to the brain. And it happens by two different pathways, ischemic strokes. Embolism, which is a clot that's formed somewhere else and travels and blocks an artery in the brain, and that's called an embolus here, or a thrombosis, which is very similar to our heart attack, where you have a blood clot that is formed in place from a ruptured plaque, and that also can cause stroke-like symptoms. About 80% of the strokes are from emboli or thrombus. Keep in mind that an embolus is a clot that started somewhere else and traveled. That's why atrial fibrillation is such a big deal. That's why you see so many commercials on TV for things like Xarelto or Eliquis, where people who have atrial fibrillation or an irregular heartbeat where these little clots can be made are on these medications to protect them from stroke. Whether it's an embolic or a thrombotic stroke from a thrombus, they're both ischemic strokes, meaning they block the way for good blood flow. Platelets are involved to a certain extent, and you wind up with a blockage downstream. Less than 15% of the strokes are from hemorrhage. When hemorrhage happens, that is from a rupture of a vessel. And if there's rupture of a vessel and blood goes out of the vessel, then there's no flow down. What's important about hemorrhage as opposed to ischemic is the CAT scan. And that's why we have to get a CAT scan right away. We need to see whether or not there's bleeding, and if there is bleeding, where that bleeding would be. So here is a brain tissue found in postmortem, and here's a tiny little stroke, an embolic stroke that occurred probably from atrial fibrillation, and it traveled into the brain, and as it traveled into the brain, it clotted off this area, and the patient had a stroke. Of course, this is post-mortem. So this patient may have had, you know, a serious enough stroke that they wound up dying. Blood clots can arise from the heart as a result of AFib. I already talked about that. It could be from artificial heart valves. It could be a result of valvular disorders where people might have abnormal heart valves in their heart, and because they flap irregularly, they can cause, keep in mind that red blood cells are tiny, and if they wind up beating on each other or something irregular, they can break. When they break, that winds up calling in platelets. When platelets come about, clotting occurs. It could happen after a heart attack or with congestive heart failure. They can also emboli, can also form from fat particles like a broken leg, from tumor cells, or air bubbles, such as an air emboli. That's the famous one where you see where somebody injects air into somebody's IV line and can cause a stroke. So once in your brain, the embolus will eventually travel to a blood vessel, and then it will hit the end of the road, and wherever that vessel is, like right here, it hits the end of the road, nothing's getting past it. It lodges there, and it causes a stroke. And you can see this area of dark. That's called the penumbra. And that area of dark is the area of brain that's going to be affected. Now, it depends on where it happens, but if it's something like the middle cerebral artery, which this is kind of depicting, it could be their ability to talk, their ability to lift their arm, or actually maybe even cause facial droop, etc. Again, a thrombus can happen. A thrombotic stroke is when a blood clot forms in one of the arteries of the brain, just like an embolus. And because of a broken plaque, it starts to collect platelets and it blocks the road to flow. A thrombus can be caused from atherosclerosis, which is also known as hardening of the arteries. Folks who have high or low thyroid, oral contraceptives such as estrogen, young patients or females who have strokes are usually have a stroke because they're on oral birth control pills. It can happen in a group of folks such as sickle cell disease people or people with other coagulation disorders where they form blood clots. Thrombotic stroke will happen just like an acute coronary syndrome. If you remember a couple lectures back, I talked about acute coronary syndrome. And when this plaque, which is essentially cholesterol, ruptures and exposes the plaque to the platelets begin to form adhesion, and a thrombus can happen right there. The subendothelial collagen or subendothelial cholesterol meets the platelets and causes a blood clot. And the platelets become activated and they all rush to the area trying to cause a blood clot and will actually wind up blocking this vessel in the brain. Brain cells, when they don't have a blood supply, become infarcted, and that area of the brain can die. The dead cells will actually release chemicals that set off a chain reaction called the ischemic cascade. So more and more brain cells will die as more and more bad substances are released into the circulation. This chain reaction endangers the brain cells itself and the larger surrounding areas of brain tissue. So here we are looking at, here is a thrombus. It could be an emboli, but they both cause the same thing. The area in the blood supply is compromised. You can see that blood flow is supposed to go this way, and it causes an area here called a penumbra. The penumbra is very important because here's infarction, here's dead brain tissue, this white. And the penumbra is that area just outside that's not quite dead yet, but it is dying. And the sooner that we can get this clot out and remove this clot so that we can restore flow, the better chance that this penumbra will not grow, and then a smaller area of the brain will be affected. The difficult thing about the brain is certain areas of the brain are important for very specialized movements or speech or memory. And if you have these infarctions, you lose that ability. The brain can sometimes reroute itself, and by rerouting itself, it kind of finds a new pathway to get to the proper way to move an eye or speech, but that takes a lot of time, months to years. So our goal is to decrease this penumbra as soon as possible. Without prompt treatment, here is a penumbra, here is an area of infarction, this white, and the penumbra around it. And this picture is an ischemic penumbra of the left middle cerebral artery. And in this particular patient, that's a large area of brain that is not being supplied and affected by stroke. So injury or death of the brain tissue happens with this interruption of blood flow. It can be caused by two things: the ischemic stroke that we've just talked about, or a hemorrhagic lesion secondary to some type of hardening of the artery or high blood pressure, or it could be a ruptured vessel or something like that. And we get sometimes a sudden loss of consciousness followed by this paralysis. Some people have a syncope or a seizure at the beginning of these strokes, which may be caused by hemorrhage or embolism or thrombus. It's very, very important for the paramedic to obtain a complete history. Try and find out, and it's very important to find out, did this person have previous neurologic symptoms? Have they had TIAs in the past? What was the initial symptom and how did it progress? Did it start as just ability to not, facial droop, and then went on to speech difficulty? Was there a change in the mental status? What were the precipitating factors? Did it happen after chest pain or exercise? Was there dizziness associated, palpitations associated? And does that patient have a history of high blood pressure, cardiac disease, sickle cell disease, and a previous stroke? If you have a previous stroke, your chances of having another stroke are significantly elevated. What is the difference between a TIA versus a stroke? And a TIA, also known as a temporary ischemic attack or a transient ischemic attack, some people call these mini strokes, are in fact just that. They're temporary stroke symptoms. They're usually caused by very small emboli that remove themselves over time. They can commonly last several minutes to hours in some cases, and usually they leave no evidence of neurological deficit after the attack. A TIA is a harbinger for a larger stroke to come. So if people have a TIA, it kind of heightens our senses to get treatment on board, to get that patient looked at and make sure that we don't have a stroke in the future. This is a very busy slide of the circulation of the brain. Just keep in mind that the majority of the vessels that we talk about are going to be the middle cerebral artery, internal carotid artery, and vertebral arteries, and these anterior and posterior cerebral arteries. And these are the ones that, depending on where the stroke goes and where the stroke lodges, we worry about treatment and signs and symptoms. Most all of these larger strokes come off of what we call the circle of Willis. The circle of Willis is at the base of the brain. So if you were to take the brain out of the skull and flip it upside down, you would see the circle of Willis. And these are the ones that we can get to if we have a neurosurgeon or a radiologist who has the ability to put a catheter into those arteries and grab clots. We'll talk about that in a few minutes. The other arteries that arise from here are the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. And these are the ones that are most easily gotten to by what we call an interventional stroke doctor. Either a doctor who is trained in, a neurosurgeon who's trained in grabbing clots. What happens is they go into the arm, they feed a catheter up, and they eventually get into the artery at the base of the brain, and they can actually grab the clot and remove it. The anterior cerebral artery, which you can see is in white here, supplies the frontal lobes and the part of the brain that control logical thought, your personality, and then voluntary movements, especially in your legs. A stroke in the anterior cerebral artery usually results in opposite leg weakness. But that's why sometimes these anterior cerebral arteries are so devastating, because a person's personality is locked up in there, and their ability for logical thought. Middle cerebral artery, probably the one that we see most often, is the largest branch off the internal carotid artery. Here's your internal carotid artery, which is in your neck, and it supplies a portion of the frontal lobe and then the lateral surface of the brain itself. It has to do with primary motor and sensory areas of the face. That's why people wind up with a facial droop. And in the dominant hemisphere, that area of speech. So somebody's left-handed, their right brain is going to be the majority of their dominant hemisphere. So if you had a right middle cerebral artery stroke, then you could possibly lose your ability to speak. And then the posterior cerebral artery in white here supplies the temporal and occipital lobes. And you can wind up with color blindness, failure to see to and fro movements. You wind up with this verbal dyslexia where you're not able to talk correctly, and some people even suffer from hallucinations. The most common finding in occipital lobe infarction is a visual field defect on the opposite side. And lastly, we've got what are called lacunar strokes. The lenticulostriate arteries are these tiny little arteries that come off. Very often we'll see these and in areas of a CAT scan that is called a lacunar stroke. And they're so small that you really can't do anything about them. The penetrating arteries that branch off the middle cerebral artery, this is the middle cerebral artery, and a stroke in those areas is called a lacunar stroke. So keep in mind that the area affected by a stroke depends on which blood vessels are damaged. And we've gone through the anatomy of those and the signs and symptoms. All right, what can we do to diagnose a stroke? And this is where EMS starts to come into the limelight, because EMS has the ability to not only determine if a stroke is happening, but perhaps where to take a patient. So this is your basic FAST. Face, right? Have the patient smile. Is it normal or abnormal? Extend their arms with their palms up like Frankenstein, and watch if both of them, they can hold up both of them, or if there's weakness. Articulate their speech. And the best way to do that is have, stroke victims are a little tricky because they know something's wrong, and sometimes they can actually even talk, but part of their brain is short-circuited, so you have to ask very specific questions. You say to them, please repeat after me. You can't teach an old dog new tricks. Now that means that they're hearing, they're understanding you, and they're able to articulate right back to you, you can't teach an old dog new tricks. Now it could be something else. It's Always Sunny in Philadelphia, or whatever it is that comes to your mind that you will remember, and that patient has to be able to repeat it to you without any difficulty. If they can't, that's a possible sign of a stroke. And last thing is T, the time. What time did it come on? And of course, these are your basics. Numbness or weakness in the arm, face, or leg. Maybe confusion or difficulty understanding speech. Trouble seeing in one or both eyes. Dizziness or loss of balance and coordination. Or severe headache. Severe headache might be a sign of a bleed. And that's the difference between an ischemic stroke and a hemorrhagic stroke. That's why we need a CAT scan. Because if they're bleeding, then we need a neurosurgeon. We don't need somebody to give them TPA and worsen the bleeding. The C-stat is a little bit of a extra trick that helps us figure out a large vessel occlusion. Keep in mind, we talked about the middle cerebral artery, the posterior cerebral, and the anterior cerebral artery. Those are all large vessels. So if you have a C-stat that's positive, then you have a higher chance that there's a clot in one of those large vessels of the brain that somebody who has the training can go in and pull that clot out. So you're going to have the patient look with both eyes in one direction. So if they're unable to look in a certain direction with both eyes, they can't look right or they can't look left, follow my finger, then that's a score of 2. If they have arm weakness and they can't hold their arm up for at least 10 seconds, that's a 1. And their level of consciousness, if they can at least 1 or 2 level of conscious questions and does not follow at least 1 or 2 commands, touch your finger to your nose, grasp my hand, then they could have a score of 1. So if they have a total score of 2 or greater, then they are what we call C-stat positive, and the chances of them having a large vessel occlusion is much higher. These are the people who need to get to a stroke center so that they're closer to somebody who can pull that clot out. So locally here, if we have a positive fast screening and a C-stat that's positive or negative and the symptoms are less than 6 hours old, we try and get them to a stroke center as soon as possible. Or if EMS and ED fast screening is positive and C-stat is positive, and the onset of symptoms is up to 24 hours now, they need to get to a stroke center as soon as possible. This is the number that keeps getting pushed out a little bit each year. 24 hours, even now I've seen 36 hours where people with stroke symptoms still go to the cath lab and they'll try and remove that stroke. We have in our area a stroke 1 direct transfer number so that people know that the stroke is coming in, and we alert the emergency room to let them know that a CT scan needs to get in and clear the table. The pros of the C-stat that we just talked about is it's a weighted scale. Gaze gets 2 points. It's fast, it's highly sensitive, it's completed pretty quickly by EMS, and the bad thing is that it's only moderate specificity. So we're doing the best we can to declare right away that it's not the most sensitive test in the world. But you guys can't do CAT scans in your ambulance, and that's the important part. So treatment by EMS. What are the treatments? ABCs, airway, breathing, circulation. Make sure that they're getting oxygen if they're hypoxic. Recognize the stroke and establish the time and onset of the history. Perform your neurologic exam. Check the glucose. I cannot stress that enough. If I get this patient and you say, the first thing I'm going to say is, what's their glucose? And you tell me, I forgot. And then my nurse checks and it's 30. That kind of slows everything down. I got to watch and see what the person responds to give them some glucose and see if their stroke symptoms go away. Early hospital notification and rapid transport. And I would add to this transport to the correct facility, depending on the ability for a place to do a CAT scan and even give TPA if we're going to do what we call drip and ship. Because when they get there, we're going to do a CAT scan. If they're still having symptoms, we're going to do a CAT scan with dye to see where that blockage is. And then before I put them back on an ambulance or a helicopter to get to a neurosurgeon or an interventional radiologist, I'm going to start some TPA. In the emergency department, very often we have what we call a differential diagnosis. We have to figure out what else it could be. These are all the things that masquerade as strokes. Syncope or seizures. Bad migraines can act like a stroke. Hypoglycemia, I already talked to you about. Hysteria, which can happen. Intoxication, somebody's drunk. They could be slurring their words. They could be having a bleed in their brain or an infection in their brain. Or in fact, it's not a stroke at all, it's a brain tumor. And they can have a brain injury from the brain tumor. It could be multiple sclerosis or some type of peripheral vertigo. These are the things that we're going to figure out by doing EKGs, blood works, CT scans with and without contrast. Advanced diagnostics, which are done in the hospital, the NIH scale. I'm going to do the neurologic exam that you do, but I'm going to repeat it with 25 different areas that I do. I'm going to get a CAT scan, maybe an MRI. I might get special imaging with that CAT scan, and angiography, which is essentially a CAT scan with dye. I might get a carotid ultrasound or a cardiac echocardiogram. These are all things that you cannot do in the field. And then medical treatment. I might start TPA to break down that clot, get them to somebody who can retrieve the clot, begin antiplatelet therapy with aspirin, or bring their blood pressure down to protect their brain. And very often I'll have what's called permissive hypertension. I'll allow their brain to have some high blood pressure because that brain is trying to break that clot on its own. So what is the goal for stroke management? And then the goal is door to needle in 60 seconds. And what is needle? Needle is the TPA. So these are our goals to try and get a stroke patient to the hospital, and within an hour, I've got all the answers that I need. I want to get my physician evaluation as quick as possible. I want to let the stroke team know that I have a stroke. I'm going to get my CAT scan to do everything that we just talked about. I'm going to look and interpret those images and then decide if they're going to the neurologist or the neurosurgeon or the interventionalist, and it's going to be a little bit of time before I can get them there. I'm going to start TPA. What does the interventionalist do? All right, here is somebody who's got a clot in the middle cerebral artery. What the neurointerventionalist is going to do is slowly snake this stent up, just like that, and then they're going to open up this clot retriever. They're going to blow up this balloon, they're going to grab the clot, and then they're going to pull that clot backwards and reestablish circulation. It is a very tenuous procedure. It takes a lot of skill, and it takes somebody who's been trained to do it, to know where they're going. So our goal then is to prevent right away by getting a CAT scan. We're going to see whether or not this is a stroke that's caused from hemorrhage or subarachnoid hemorrhage. We don't want these two people getting TPA, because if we give TPA or clot busters to both of these people, will actually make their bleeding worse and will make their stroke worse. Sometimes there's a hemorrhagic conversion. Note the area of white tissue that was bleeding surrounded by ischemic tissue. This is not somebody that we would give TPA to. This is somebody that a neurosurgeon would have to go in and maybe put a clip on the artery or something to that effect to stop the bleeding. All right. And that's the end, and that gives us about 10 minutes for questions.
Does anybody have a specific question before I start picking on you one at a time?
Oh, there might be more than one of us. My
Yeah,
question. Oops, sorry. Go ahead.
Okay, go ahead. No. I have a question too, but you could go first. Yeah.
Mine might be kind of a dumb question, but what are the best ways if someone has a TIA to prevent from having another stroke? Is there a way for them to prevent that?
Yeah, so the question is, how do you prevent a TIA what's the treatment for TIA, and essentially the workup for TIA is pretty extensive. You're going to look at the carotid arteries, and you're going to find out if there's disease in the carotid arteries. Sometimes that means getting surgery in the carotid arteries to prevent narrowing of the vessels. You're going to probably put them on either warfarin or enalapril, no, I'm sorry, not enalapril, Xarelto or something like that to make their platelets more slippery so that they don't wind up with a clot again. And then you're going to look and see what's causing it. You know, are they an AFib? And if they're an AFib, you're going to want to put them on something that keeps the rate down and keeps them from clotting, like I talked about, either warfarin or Xarelto or something to that effect. So the treatment for TIA is to be very vigilant and suspect that another stroke could be coming down the pike at any time.
I have a question, sir.
Go for it.
Is there any way, and if not now, possibly in the future, to differentiate if it's, because I'm assuming the only reason you can't give aspirin is because it could be a hemorrhagic stroke. Is there any way you could tell in the field, get an idea?
The question is there any way to tell if it's a hemorrhagic stroke in the field? And the answer is no, except by maybe history. You know, if somebody fell and hit their head, that's more consistent with a bleed. But strokes are kind of sticky wickets. You know, there's no way to absolutely tell just by the physical exam alone. That's why people need a CAT scan, and that's why if you think back to your, you know, advanced cardiac life support or your PACLS. It'll tell you that one absolute contraindication for a place being taking a patient to a certain hospital is if their CAT scan is down. If their CAT scan is down, you can't determine whether or not they're bleeding, if their stroke is from bleeding or hemorrhage, and they need to go somewhere else. So when that happens, if our CAT scan's ever down, we go on divert. And we say, you know, take them somewhere else.
Awesome. Thanks, sir.
Hi, doctor. I have a question.
Go ahead.
Yeah, okay. My question is this. We talked about permissive hypertension. So let's say we go to pick up this patient and his blood pressure is really high, 180 over 100. We still try to bring the blood pressure down, right, during the transport, or we still have a number we need to bring it down to, like a systolic and diastolic, a certain number, while we're giving oxygen and transporting to get the CT scan done?
Well, in stroke, the answer is no. We usually have that permissive hypertension because what's happening in the brain? The body knows that it's having a stroke. The brain knows that it's not getting enough circulation. So it purposely increases the pressure in the brain to try and blow that clot out. So if we drop the blood pressure, then we're actually countering the body's natural tendency to do that. So what I would do once I have a diagnosis of a stroke is I might give them some labetalol and try and bring down their pressure so they don't wind up with as large a stroke. But at the same time, I'm not going to randomly just start treating the blood pressure. It's a tightrope. And you guys, there's not really much that you guys could do in the field with that high of blood pressure. You know, you could give nitroglycerin or something, and that would just not be appropriate for a stroke.
Okay, thank you.
Meshalem, what about you? Do you have a question?
I was actually about to get to it. I somehow, for some reason, it cut out when you were talking about, when the doctor was talking about why it's important to check for hypoglycemia during a stroke. It cut out. Is there a reason? Is there a specific reason why during a stroke you'd be looking out for that?
I'm sorry. I guess I didn't quite. Can you repeat the question one more time?
I think what he's asking, Dr. Eschebach, is he wants more information on checking for hypoglycemia, the reasoning behind. I don't think he's following about the symptom overlap.
Well, the reason you're checking for hypoglycemia is if you have a blood sugar of 30, you're going to have trouble concentrating. You're going to have trouble with your words. You're going to have confusion, and you're going to have signs and symptoms of a stroke. So if somebody has a blood sugar of 30, they might appear like they're having a stroke. And what's the treatment for a blood sugar of 30? Sugar. And they're better, as opposed to rushing them to the hospital, getting them a CAT scan, rushing them off to a neurosurgeon, and then you find out later that their blood sugar was 30.
So it's just like all AMS patients, you'll go always check the sugar.
Absolutely.
Okay, just confirming that. Thank you.
You're welcome.
Jennifer, it's your turn.
Yes, sorry, I couldn't find the mute button. I have no questions.
Excellent. Well, that's good too. Dusty, how about you?
Well, Shaughnessy kind of asked similar to what I was wanting to ask, but I guess I'll kind of expand on that. If you have a series of TIAs, at which, obviously that's going to lead to a stroke at some point, the more TIAs you have, does that make a more severe stroke when you finally do have the big one?
Well, the question is, are TIAs additive? And no, they're not necessarily additive, but they are a harbinger or a predictor for a worsening stroke or a large stroke. So somebody who has a TIA, the chances of them having a stroke in the near future are much higher.
But it doesn't have anything to do with severity at
No,
all?
they don't really add up and predict each other.
Okay, thank you.
Carmela says her microphone isn't working, but she says her EMS system uses the RACE scale. What's the difference between the CSTAT and the RACE scales?
The difference is they're very similar. You can, if you look at your advanced cardiac life support or American Heart, they're going to have a Cincinnati scale. They have a Los Angeles scale. Whatever it is, they're all about the same type of signs and symptoms. And you have to determine what one you remember and what you have, and whether or not there's weakness, facial asymmetry, difficulty with words, weakness. All of these are brought into that. And if you bring CSTAT into it, whether or not they're oriented, lateral gaze, or ability to hold up their arms, that makes it a little bit more precise for a large vessel occlusion.
Very good. Jody, I know you're an EMT student, but this subject is pretty broad across all levels. Do you have any question?
Yes, actually, I'm just curious why the time of treatment has changed so significantly over the years.
That's a good question. Why is the time of treatment? Well, initially it was 3 hours, then it was 6. And what happens is people do studies and people try and push the envelope. And as long as they keep pushing the envelope and taking people to the cath lab and getting more and more numbers, we're going to find out that some people get better if it's 24 hours and they've had that blood clot in there and you remove it. They might, in fact, get better. So stroke centers are continually going to push the envelope. And when you push an envelope, times will change.
Thank you so much.
Great question. Lewis, how about you?
Hi, Dr. DrEschebach. So this is pretty interesting that we're actually covering this material now. Just last shift, we had a stroke patient here in rural Montana, and so we launched Lifeline. And so obviously it's time. We're in a rural setting, so getting the patient to where he needs to be was of the essence. But I guess for us, there's that field drug of TPA, and what are your thoughts on that as far as using it in the field for that kind of patient?
You mean TPA in the field?
Correct, yes, sir.
Well, unless you're getting a CAT scan in the field, you can't give TPA.
Right, and that's what I was reading up on, I guess, because obviously if you're having a hemorrhagic stroke, then you don't want to give the blood thinner.
A hemorrhagic stroke and an ischemic stroke are going to present with exactly the same symptom.
Right.
And if you give TPA in the field without having a CAT scan and somebody's bleeding, you just signed their death warrant. So
pretty much. Okay, gotcha. I think this guy ended up being flown to Salt Lake from the hospital we transported to, and he ended up having a basilar stroke.
Yeah, and what we do in those things is a drip. We call drip and ship. We start the TPA and we get them to a definitive stroke center.
Gotcha. So you're saying, I guess, essentially just O2 and get them to the, the nearest appropriate facility for
exactly.
treatment. Okay.
You can do the CAT scan and then go from there.
Gotcha. That's it. Thank you.
You're welcome.
And Marilyn, how about you, my lady? Marilyn, are you there? Ah, she's typing. Hi, Marilyn, do you have any questions? We're a second to type. Please, can you touch on a mental stroke?
Mental stroke. If you're referring to decreased level of consciousness, which can happen in any stroke, I guess, decreased orientation, that's the only thing I can think of would be a mental stroke.
She said that I just took a patient to the ER and that was the diagnosis.
Mental stroke.
Yes, you got me.
Well, if you recall, one of the things we talked about in the differential, let me see if I've got this up again. Let's go to our differential diagnosis. Sorry. The only thing I can think of is, here we go, right here. Hysteria would be something that people think they're having a stroke and they're not. They might be hyperventilating. If they're hyperventilating and they have tingling in their mouth and spasms in their hand, that would cause an anxiety reaction, and they would wind up not having a stroke at all, but that would be a conversion reaction. And a conversion reaction might be considered a mental stroke, although I've never heard the term mental stroke.
Yeah. Okay. Well, everybody, I'll have this probably put up on the board or in the MD roundtables for videos if you want to review it in a few days. I'd like to thank you, Dr. Eschebach, and the next MD roundtable is scheduled with Dr. Frame on Friday, March the 3rd at the same time, folks. Jody, I gave you credit for a chat since you're not required to be in here, so I marked you off on one of your chats, but I do encourage you to still go ahead and do chats as well, because they're a totally different format and how that's done. It's interactive, so I still recommend that you do that. Everybody else, check your grade sheets, make sure I gave you credit, and thank you very much. You had great questions, and this was a great lecture.
All right, thank you.
Thank you.